So I'll start by professing that I'm not a lung transplant expert by any stretch of the imagination. We have a whole separate lung transplant group at the University of Chicago. But I do have a few slides which I think will at least answer the questions, and Jim or Roger, feel free to chime in as I go. So general guidelines for listing patients are obviously patients with poor prognosis without transplant, looking at a 2.5 to 3.5 median survivorship. And the idea, of course, is to get the patients with the highest mortality on the waiting list. Is it not? Okay. So who are we looking at? We're looking at patients with a DLC, well, referral or for patients with IPF with a histologic or radiographic diagnosis, or fibrotic NSIP. We recognize that the fibrotic NSIP have a poorer outcome than the cellular NSIP. I didn't go into any of that discussion, but the bottom line is if you have an interstitial lung disease that's of a fibrotic nature with a high mortality, these are patients that are going to get referred. And the criteria will start to look very similar to the same prognostic criteria I talked about before. They really link right back up to the same data set in that patients with a DLCO of less than 39% are going to have a higher risk of mortality and therefore be considered for listing. A decline in FVC by greater than 10% over a 6-month period, as we talked about before. Oxygen hemoglobin desaturation of less than 88% on a 6-minute walk. Honeycombing on a CT scan, or NSIP with really the same criteria. Now, one of the questions that comes up is, are you better off with a single or are you better off with a double? And it's kind of interesting in that there's a growing body of evidence in all transplant groups that a bilateral lung transplant is better than a single. And you know, it kind of makes some common sense that that would be the case, but it's a resource and it's a limited resource, and so you have to take other elements into account. And indeed, as it turns out, in idiopathic pulmonary fibrosis, what this slide shows you is it isn't worth waiting for a double. That the incurrent risk of dying while you wait in order to get a double will eliminate the benefit that you actually got from having the double. And as Jim pointed out at the break, the truth is, from a functional standpoint, there isn't a real difference. And again, Jim, you can chime in, but if I remember correctly, the real issues with the benefit on a double have to do with really more with infection soiling from the other lung, and that's much more in the CF group than it is in a pulmonary fibrosis group. And this just kind of shows you what the survivorship has been like and how it's developed. One of the interesting things about IPF is, I'm going to say two things that are kind of contradictory. It's actually got one of the worst survivorships of lung transplant patients, but the highest benefit. How do you reconcile that? The risk of death is highest in IPF relative to COPD or some of the other groups. COPDers, patients with COPD, from a mortality standpoint, can actually kind of go on with very severe disease for a very long time, whereas IPF patients don't. And so the years of benefit that they get are actually very high. The mortality is the highest, but you got to remember it's also one of the oldest age groups that get transplanted. And so I think that some of that really kind of carries over and is probably an explanation for why that is. And the curves here show you the groups with IPF being the lowest yellow one. The laser's hidden here in the corner. IPF kind of starting the same as everybody else and then having one of the lowest Kaplan-Meier curves, but not by a lot. The differences aren't great. And you can see very little difference with the COPD group, which again has that same age-related issue. And then this just shows you that original separation that I talked about. As you move further out beyond the 5-year mark, there is an incremental benefit to the double over the single, but it's not a whole heck of a lot. And it certainly isn't worth waiting on. And you know, the other part is a real resource question, right? Everybody who gets a double means that there's somebody who didn't get a single. And so that's part of what goes in the equation. And at least at the moment, there are still more people on the list than actually get transplanted or for which lungs are available. And so that's a lot of the rationale that goes for that. So for the evaluation, you want to look at the high-resolution CT scan to make sure that there isn't an underlying cancer. Nobody likes to transplant a patient who's got cancer and find out about it after the fact. But early referral, and that's one of the things I kind of finished up my talk on, it's better to get involved early if there's an interest, and the reason is that there's a great deal involved other than just the surgery. There is, a need for a tremendous amount of social support involved in transplant. And the transplant centers are all usually very excellent at that, but it's an entire system and process. Getting into pulmonary rehab, getting all the ducts lined up so that the best possible outcome can be had after the surgery. Certainly desaturation considerations come into play. I had a patient that I got transplanted a couple of years ago by basically knocking on the transplant surgeon's door and saying, look, the problem is that the surgeon often doesn't see you. There's a panel that kind of goes through this. And so we evaluate the patient goes to a transplant pulmonologist, and they kind of present them. And it's kind of a sight unseen exercise a lot of the times. So I kind of knocked on his door and said, I know what this looks like on paper, and they wanted an Nissen fundoplication, which has been demonstrated to improve survivorship afterwards. And I said, he's on a rapid spiral down and won't survive the next 4 weeks. If you wait for the Nissen, he's not going to get it. And when he finally saw the patient, he agreed, and the patient was transplanted actually within 3 weeks. And the Nissen got done several months later. So, there are elements of that, and it's better to be involved early because that's what happens when you have on the short run and on the downward end. And then they obviously look for the criteria for best candidates. So, and as I mentioned before, the old criteria in 2005 was really a first come, first served. And now it's based on an urgency and needs basis using a lung allocation score. How sick is the patient? How long will they survive afterwards? And they use a computational analysis to kind of figure that out. And those are really my slides. And this is what kind of goes into the calculation. But that isn't so important. What's important is if you're going to think about transplant is getting involved early so that they can kind of go through all of these pieces. They like to make sure that if you have coronary disease that it gets fixed. Nobody wants to take a patient to a lung transplant and have them have a heart attack as a result of the stress of the operation on something that can be remedied. And all of that kind of takes time. And that's why I kind of really approach it as early as possible. And that's my 5-minute spiel.